in as soon as well, as long as ultrasound has become more common and more easily available, and its musculoskeletal use has become very clear, it has become a common office procedures in Western world, especially in United States and UK. And most of the injections, corticosteroid injections especially, is done ultrasound gated. Why ultrasound? The first thing is, between 2000 to 2009, there is a 71.7% increase in diagnostic ultrasound alone in United States, and most of this done in sports medicine. The reason is, it's easy to image muscle, soft tissue, and cortical bone surfaces, not exactly the bone as good as X-ray, but cortical bone surfaces. And it's not known to have any long-term effects and nil radiation effects, so it's kind of easy to do in the office, as well as you can see static and dynamic images live. And the machine portability is another important aspect of having the machine available as part of your medical kit, to take it and then just do it on a bedside or do it on a pitch side. As well as there is no special requirements required as such until the point you want to inject in a sterile conditions. And the resolution is reasonably very good, up to 1 mm high resolution ultrasound, portable ultrasound images or devices you can get to do it. And it's quite accurate and effective in terms of identifying certain pathologies, not all, but certain. And it's cost effective compared to MRI in terms of diagnostic use, as well as it gives a bit more guidance in terms of whether if you decide to go down the route of injecting. And again, the advantages repeated again. It's relatively inexpensive. It's diagnostic, as well as you can do a therapeutic procedure then and there if you think it deemed necessary to inject it. And nil radiations. Again, the biggest thing is its cost. Cost is relatively 1/10 of a cost of an MRI to identify certain soft tissue dysfunctions or soft tissue diagnosis like bursitis or tendinosis or tendinitis. The disadvantages usually are, rather than going down the disadvantages, the main disadvantages is it always accurate? No, it's very operator dependent, and a lot of training required, or at least up to 100 ultrasound for an radiologist to do it in order to get the pathologies consistently right with regard to ultrasound imaging. So there is a huge amount of operator error or operator dependency there. Why do you need guidance? The blind injections has poor ability to get into the desired joint blindly, because you just go with your hands-on feel and clinical experience to say that yes, I'm there, I'm there or thereabout. You're really not sure whether you're accurately there. In studies done, the glenohumeral ultrasound guided injection has 90% accuracy rate compared to 27 on a blinded injection. Likewise, the biceps tendon sheet injections, subacromial space, and AC joint and hip joints. Whereas the smaller the joint, the easy to use the accuracy goes up to about 100%. So the gated injection, what is the evidence base for gated injection? The American Medical Society for Sports Medicine actually did systematic evaluation and level 1 studies, and they looked at what is the accuracy, efficacy, and cost effectiveness of ultrasound gated injections in major joints, intermediate joints, small joints, and soft tissue. While the major joint, the level 1 evidence is about accuracy is between 91 to 100%, except a sacroiliac joint, which is not commonly practiced as a gated injection procedure, whereas shoulder and knee and hip joints are commonly done as an ultrasound gated injection procedures. While it goes down to the intermediate tissues, again, certain joints are easy to do, certain joints are not easy to do, and smaller joint, the accuracy rate increases close to 100%, as well as in the soft tissue conditions. Efficacy, again, the efficacy is debatable, depends on what you inject, why you inject, when you inject, and what is the reason behind your option of injecting. So when we look across the evidence base, the SOT is the level, predicts the ability of what is the efficacy of each level 1 studies to say that it is definitely effective in terms of accuracy and efficacy. And the first generation techniques like ultrasound gated aspirations, injections, perineural injection have a level A evidence which is quite high in compared to the second generation ultrasound gated procedures like needle tenotomy, fasciotomy, and fenestration of transverse carpal ligament in terms of a carpal tunnel symptom before you want to offer them a definitive option of surgery, etc. And there are advancement happening in ultrasound-guided injection or ultrasound-guided procedures in terms of even doing certain selective surgical procedures using ultrasound as a guidance. I just recently come across a paper, which I'll put the reference of the paper at the last. In sports medicine, why it's in sports medicine? I think the main reason we choose in sports medicine as a time to buy or a quick intervention to early rehabilitation. Say, the advantage we have is we have a very limited window in terms of getting these players fit and quick, and we want to really control the pain and inflammation. The earlier, the sooner, the better in terms of for us to progress them through the rehab stage. And it's actually buys us time to rehab them faster, quicker, before we offer them any definitive treatment options when the injections fail. So again, it can be therapeutic as well as diagnostic. So when you look across a pitch side evaluation of a serious injury or an injury that looks very serious at the outset, whereas you do an immediate evaluation with ultrasound, the injury is not as serious as you think about. It helps you to decide whether is the player fit to play, or is there a reason where we have to pull them back, not make the injury worse. As well as it's better than landmark guided procedures. So mainly in sports medicine, we use it as a temporary measure most of the time than a permanent solution. So the conditions we use in sports medicine, again, as you all know, intra-articular or peri-articular injections in terms of an acute subacromial bursitis or tendinitis. Usually we use corticosteroid injections, and in some cases in an osteoarthritic knee, you can do a viscosupplementation if required. PRP injections nowadays, you do an MRI to diagnose the level of muscle injury and then decide you want to do a PRP injection, but you want to know definitely you're injecting into the injured tissue and the level, then ultrasound-guided procedures are used. Perineural injection, the most common one is carpal tunnel syndrome injections and motor neuroma injection. Peritendon, Achilles, which is quite controversial. Some people say try not to go down the route of injection as much as possible, but if you do it, try to inject the peritendon sheet rather than actually in the intratendon, as well as there are procedures like ultrasound-guided hydrodissections procedures available. And in enthesopathies and in case of rheumatoid arthropathies, injections can be used as an effective means to treat those conditions. So there are a few examples. Basically, the main advantage is visualization. Say in terms of if you want to inject into intra-articular glenohumeral joint, comparatively you could see the needle where it's going, and are you exactly in the joint space for you to inject the injectile where you require to inject, and are you really delivering the dosage what you require or the medication required in the exact area. And the most important advantage is you minimize the damage to the other tissues. Say when you do a blind injection, you might end up, you think actually you are not in the joint space, or you are actually maybe in the just above the joint space or just in the intramuscular tissue. So it minimizes the inaccuracies of injecting blindly. So there are a few examples. The posterior approach is most commonly used in terms of glenohumeral injections, with a single operator used, a sterile technique where you visualize the structure you want to visualize, get the joint space in a line, get the needle perpendicular to the probe so that it's easy to see the needle where it's exactly going and delivering the medication to the target tissue. So again, there are a few more examples of glenohumeral joint injection, which is quite commonly done in terms of periarthritic or frozen shoulder, subacromial bursitis, which is the most common things we get injected, and in the subacromial space, as well as you can have injections into bicipital tendinosis where you want to do bicipital tendon injections. The most important thing is I think it's a skill that helps you to deal with certain conditions in office effectively and quickly for you to progress your patients or an athlete to earlier rehabilitation, and as well as give better rehab outcomes to that particular patient, as well as earlier pain relief. Because the earlier you control the pain and inflammation, the quicker you restore the function. The quicker you restore the function, the quicker they get better, as well as their efficacy of whatever they do, especially in sporting conditions. They were able to give 100% performance-related goals that required, which is not possible otherwise because of pain. So a few more. The idea of this lecture is to show you a few slides as well as show you a few procedures, but not to go through in-depth detail of the procedure, because it itself is a training course that need to be done for about 3-4 days, and then you have to build up a volume of over 100 scans and gated injection procedures to master the technique. So there are a few more areas. Acromioclavicular joint. I just want to ask a question. How many of you think a blind acromioclavicular joint injection is accurate? And what is the level of accuracy? Not
Depends on who injects.
right, but even who injects, in terms of the most experienced clinician, what is the level of accuracy is not as good as when you do a gated injection. It's
High,
It's-
but 70-80%.
70-80%, whereas if you do an AC joint injection using an ultrasound gated, it's 100%. So you're 100% sure you are in the acromioclavicular joint space to deliver the steroid to make the anti-inflammatory effect that work. Few more thing that is the second generation we talk about is, I'm just going to skip few slides through. We talk about a procedure called FAST procedure. Say in terms of calcific tendinosis, where you are there at a point, okay, you could argue that shockwave works for calcific tendinosis as good as any other procedures, but when the shockwave fails and you still want to aspirate the calcific buildup, which is in the soft callus stage where you can actually aspirate, the FAST procedure, focused aspiration and removal of soft tissue using ultrasound gated procedures are quite effective and give you quicker pain relief for your patients who suffer from a calcific tendinitis shoulder. Further, again, you could do it a calcific tendinosis in a patellar tendon, in a subacromial space, especially the calcific tendinitis of supraspinatus tendon, as well as in some insertional tendinopathies with Achilles tendon where there's a bit of a calcium buildup, those sort of indications. I'm going to skip again because there are a lot of pictures and the time is restricted. So in summary, it provides a reliable in-office procedure diagnosis as well as a procedural or a therapeutic treatment option available for the consultants who is dealing with it. Low cost, it's more effective. Efficacy is something debatable, but it's more accurate and effective. And again, as done as an in-office procedure and can be used for any joints that is superficial or that is easy to access. And main disadvantage is it's a steep learning curve if you go down the route of doing gated injections, because the ultrasound itself is very operator dependent and your ability to diagnose and the ability to identify tissues takes a lot of time to learn. The recent papers I was discussed about, there is a paper published just on 2016 BMC musculoskeletal disorders, ultrasound gated gastrocnemius resection under ultra-invasive surgical techniques. So in some cases, if you want to do a procedure where you think the scarring, especially in Achilles tendon procedures, are quite extensive. So if you want to minimize the amount of scarring, you can still do the same procedure using an ultrasound gated procedure, which is being piloted upon, as well as ultrasound gated nerve hydrodissections, which especially in carpal tunnel symptoms and few other neural compartment syndromes where opening can open a can of worms. So that's the references I use, mainly the American Medical Society for Sports Medicine and as well as Kelly's presentation. Thank you very much.